Good afternoon, everyone. Welcome to this warm evening of 12th Annual Conference of Kerala Heart Rhythm Society. In fact, KHRS was formed in 2010 and 11, and we had the first conference in 2011. Because of a few unforeseen events like COVID and all, we had missed a couple of them. And in this session, we have plenty of talks, 16 sessions in fact. The organizing team had tried our level best to keep every aspect of EP included. In fact, it is a tightly packed sessions. And most of the faculty will reach by Vande Bharat. And they're planning to leave by Vande Bharat tomorrow. So we try to accommodate everyone and extending the talks and the sessions to the evening till 8:40, 9 o'clock, and starting quite early in the morning. Without wasting much time, let us initiate the sessions. And I again welcome all of you, and thanks again for coming right in time. And over to the that anchoring team for taking over the sessions and managing it. Thank you.
In this wonderful afternoon, we welcome everyone, the faculties, professors, the fellows, residents, and all the supporting staff and the organizers. With no further delay, let's start the program. The first session being Dilemmas in EP and Solving the Puzzles. Chairpersons, we welcome on the stage Dr. Abhilash SP, Dr. Anand Matanda Pillai, and Dr. Praveen S.
I think we'll start the session. We'd like to call Dr. Vikram V for the first talk, Navigating the Stump.
Respected professors and delegates of this August forum, a fine afternoon to one and all present here. I would like to thank the organizers, first of all, for giving this opportunity. I would like to present a case whom we dealt with in the chest pain unit of our hospital. It was a story of a 51 years lady, a homemaker, who presented with acute severe chest pain of around 12 hours duration. She did not have any associated dyspnea, palpitations or syncope at the time of presentation. She was a hypertensive for the past 2 years on enalapril 5 mg once daily, and she was recently diagnosed to have diabetes mellitus, and she was on metformin 500 mg BD for the same. She had no previous history of any CVA or ACS. She did not have any thyroid disorders, and there was no history suggestive of any substance abuse or poison intake. Clinical findings were unremarkable, except for a heart rate of around 128 and a hypertensive response. This was the ECG at presentation. The ECG showed a tachycardia with a sinus rhythm, with a tachycardia heart rate of around 130, with the very remarkable ST depressions in the anterior leads as well as inferior leads, and ST segment elevation in AVR. So we were thinking in the terms of a left main equivalent with the background of a severe chest pain at presentation. And she also had a QRS alternance noted. We did an initial screening echo that showed mild LV systolic dysfunction with an apical RWMA, and there were no mechanical complications noted. By the time our biochemistry team helped us with the TROPS and CKMB fast, troponin of around 6,000 and CKMB was quite high, 230. So we did a emergency, we have a primary lab close to our chest pain unit, so we did a emergency CAG. We found 80% stenosis in the proximal to mid LAD. RCA and LCX were normal, so we went ahead and did the PTCA. We did a stenting to the LAD with DES. Then this whole story started. During PCI, the patient had VT, and we had to cardiovert her and intubate her, and we proceeded to complete the PCI. We managed the VT that time with magnesium bolus and amiodarone. It settled somewhat, and there was hemodynamic compromise for which she had to be started on a low dose of noradrenaline. VP systolic came up to 100. And post PCI, we were observing her in the coronary care unit, where there was not much change in the ECG findings. Then slowly she developed another episode, and we were able to catch it on the subsequent ECG. Short coupled VPCs, which initiated runs of NSVTs. This went on and on the whole night. The patient presented around evening, and it went the whole night. The screening echo post PCI showed apical ballooning with mild to moderate LV dysfunction, and there was recurrent episodes of polymorphic VT. Patient was in cardiogenic shock. She required multiple DC cardioversions, and she was continued on NORAD. We had started her by then on lignocaine and fentanyl and midazolam infusions also. There were no fresh STT changes. All electrolytes were within normal limits. And there was relentless VT going on. Fentanyl, midas was switched to propofol. NORAD was increased to 15 mics per minute. DOPA had to be added. And just to have in mind stent thrombosis, thyro also was started. Dopamine we were able to stop after 3 hours, and NORAD increased to 20. Recheck angio showed patent stents. So quick recap at what he did. Magnesium and amiodarone didn't work. Then angio showed no stent thrombosis. Lignocaine and fenta also didn't work. Then we had to go to propranolol. Then also it didn't stop. Then finally we started her on quinidine. Then VT stopped. Extubated and monitored in CCU for 72 hours. She was VT free. By then her initial serology we had sent EBV came positive. Then we were able to do an echo in our main lab that showed a reverse Takatsubo pattern. GLS was also suggestive with apical sparing. Then we went and revisited the history. She had low-grade fever with malaise and body ache 1 week before presentation, which was not evaluated. In fact, she didn't give much importance and didn't even inform her family members. We did a cardiac MRI, which showed mid-myocardial LG intensely enhancing with faint subendocardial hypointensity. There was basal, anteroseptal, infroseptal, mid-anterior and basal anterior and mid-inferior segments, probable myocarditis sequelae. Then we did FTG PET without MIB, which was negative for myocardial inflammation. So this is her day 3 ECG. So I would like to give something about polymorphic VT Purkinje related, which is associated with short coupling interval. Originate from the Purkinje fibers at the border zones. Purkinje activity remains in areas of myocardial ecnosis. This allows this calcium spark-driven phase 2 early after depolarizations to happen and propagate and re-entry, causing very fast arrhythmias. They fail to respond to conventional antiarrhythmics, but quinidine is very effective. So thank you.
Yeah, good case. Retrospectively, we are wiser to ask questions. I know, I can imagine how it was difficult to diagnose in the initial time.
Yes.
But did that ECG explain the LAD lesion?
No, sir, it was
No,
more
it
like
did not. It did not. Probably there was some spasm in addition,
Yes.
or the whole thing could have been myocarditis.
That's why we
Myocarditis with
were
STL.
sending all the serologies and other things
Yeah, what is
simultaneously.
it? The QT appeared prolonged, no? From the
QT
very
appeared
beginning
a
ECG.
little prolonged,
So,
but electrolytes were normal, sir. We were
QT.
thinking ischemia related QT prolongation also
but
initially.
ischemia was not convincing, no?
In the
Because
initial
that is
time.
only a 60-70% LAD lesion.
Yes, sir.
Unless you add spasm to it, it's difficult to explain.
Yes, sir.
But drop T was 6,000. I
Yes.
think whole thing could be a myocarditis.
Yes, sir.
Okay.
On follow-up, how is she's recovering?
She's completely recovered completely her LV function, doing well, sir. We had the good fortune of having quinidine at the time. It's unavailable in India, but we managed to get it through one of our doctor friends who was friends with our EP head, who got us few samples. We had kept it in store.
Amiodarone did not work at all.
Did not work.
Did not work at
Did
all.
not
You gave
work.
the full bolus.
We gave infusion
You gave
also,
the
sir.
full bolus. When the QT prolonged, if it is the PVC that is the primary thing, then probably
Yes.
it may help.
We were thinking of stellate ganglion block also because it
Yeah.
was so relentless, but by then it subsided with quinidine.
Yeah. Another option is to pace at a
Pace.
faster rate. It will
Yes, sir.
pace. Pacing was, but it was very, her presenting rate was 130.
130.
130. Thank you.
Thank
We'll
you.
move to the next case.
Thank you, sir.
Dr. Punita will present cryoablation in post-renal transplant recipient. Dr. Punita, please.
Good afternoon to everyone present here. I'll be presenting a case on cryoablation in post-renal transplant recipient. So it's a 57-year-old gentleman, known case of diabetes and hypertension, which is well controlled with medication. He underwent renal transplant in the year 2006 and he continues to be on immunosuppressive, that is mycophenolate mofetil and prednisolone. In December 2023, on pre-op evaluation, he was noted to have atrial fibrillation and started on rate control medications, that is beta blocker, and as CHART-VAS2 score was 2, he was started on anticoagulation as well. In January, he had 2 episodes of recurrence despite being on beta blockers and amiodarone was considered. In February, he had symptomatic bradycardia in the form of pre-syncope. ECG showing AF with controlled ventricular rate. X-ray, there was no cardiomegaly, no pulmonary venous or pulmonary arterial hypertension. Echo-wise, he had a good LVEF with a mildly dilated LA and MR was mild. Holter, the minimum heart rate was 40 with maximum heart rate of 87. 16 beats of AF was noted and there was no significant pause. Creatinine was 1.9 mg per deciliter. So in view of creatinine post-renal transplant patients and as we couldn't get a nephrology clearance, we couldn't do a CT for him and then went ahead with the TE. So TE confirmed that there was no LA appendage clot and the LA appendage velocity was 85 centimeter per second. So in view of the paroxysmal nature of arrhythmia, significant symptoms and well-controlled comorbid conditions, he is likely to benefit from aggressive rhythm control strategy and hence after shared decision, we went ahead with the cryoablation. So in this case, contra-CT could not be done and hence pulmonary vein dilation could not be considered before. Immunosuppression, with that there is a risk of infection or delayed wound healing. Most importantly, the femoral venous axis. Because the grafted kidney, the renal vein is anastomosed to the iliac vein, so there can be anatomical variations. We were not sure of the size of the iliac vein, and hence if the sheaths, such as the 14 French sheaths, will be able to pass through it. And if there is any thrombosis or stenosis later, there can be dislodgement of the thrombus, and it could lead to graft dysfunction. So under ultrasound guidance, a femoral vein puncture was taken and thermo wire was passed. An advanced balloon 7 mm, which was inflated to a 3 atmosphere, was passed through the same. And it was confirmed that the iliac vein was well patent and hence we went ahead with the cryoablation. So basal study confirmed that the patient was in AF. With the standard methods, LA puncture was done with the BRK1 needle. And the Achieves mapping catheter was placed. It was showing a pulmonary venous signal in the LSPV, whereas LLPV did not show any pulmonary venous potentials. And the balloon was inflated, cryo balloon was inflated, and the pulmonary venous isolation was done. During the pulmonary LSPV ablation, some delayed pulmonary venous potentials were noted, but later there was disappearance of the same. And some freeze artifacts were noted during the cryoablation procedure. The RIPV mapping did not show any pulmonary venous potentials. So this is the pulmonary venous mapping, which was cryoablation done with the diaphragmatic pacing. The His catheter was placed in the SVC. And diaphragmatic pacing confirmed that there was no phrenic nerve injury. So this is the diaphragmatic pacing with the His catheter placed in the SVC. And also the CMAP did not show any reduction in the amplitude of the potentials. So when we were cryoablating the RUPV, the tachycardia organized into 2:1 atrial tachycardia, but as the signals were earliest at the 9:10, a suspicion of flutter was also considered, and hence pacing from the CS 9:10 was started, but the difference between the post-pacing interval and the tachycardia cycle length was 88, so hence a flutter was ruled out. Post that we started doing aggressive tachycardia pacing protocols, but tachycardia could not be induced. So the final ECG is suggestive of a normal sinus rhythm. This is a 3D mapping showing that all the pulmonary veins have been isolated. So there has been a study which showed that catheter ablation is safe in renal and hepatic transplant patients, which was published in the year 2020. They had followed up them for a mean of 30 months, and all the transplant recipients, when compared to the control group, had the similar difference in free from AF ablation or in sinus rhythm, and vascular complications were not noted, and there were no life-threatening conditions, and there was no allograft dysfunction. So in this, catheter ablation is safe in renal or hepatic transplant patient, and with this case study, we come to know that even cryoablation is also safe in post-renal transplant recipients. Thank you.
Presentation. When you mentioned that there were no PV potential signals, what did you infer by that? Could the catheter have been far in? There should normally be some PV potentials, isn't it?
Yes, sir. Sometimes there need not be PV potentials also, but we still isolate all the pulmonary veins because some signals like later they can develop. And catheter was also, we had occluded the catheter, contrast was injected to see that there was no contrast flow into the pulmonary vein. Post procedure 1.8, sir. And patient is currently doing well. There has been no recurrence of AF further, but he has some derangement in the OTPT, so amiodarone has been withheld. He's on beta blockers, no recurrence.
As you mentioned, one of the reasons why you don't get a PV potential is your active catheter, that multipolar catheter is deep in. Sometimes they don't fire actually, they may not have significant. They are already isolated. One out of the four, many times we get like that. Here the question was the right renal vein, anastomotic kidney was attached to the iliac vein, the vein was there. So we had a 10.5 front sheath. So we were always worried that that would occlude the vein, and that is a single functioning kidney. So we took a larger balloon. That was the idea from the radiology colleague. So larger balloon and did an injection so that the procedure went afterwards smoothly on.
Thank you, sir. Thank you.
Thank you.
Next, I invite Dr. Gobu to be ready for SVT with catamol polymorphic VT.
The patient is being followed up with Ajit itself because he only referred the case for a cryo. So this patient is fine. That's what he told yesterday. Amiodarone, they had to stop because the PT was 156. No recurrence. 3 months for the washing, the initial 3 months blanking period, we give amiodarone. Then we stop it.
Good morning to everyone. Good afternoon to everyone. I am Dr. Gopu Prithvi Reddy from Christian Medical College, Vellore. Today I'll be presenting an interesting case. A 6-year-old boy studying first standard presented with multiple episodes of loss of consciousness preceded by palpitations. Most of these episodes are associated with exertion and associated with syncope and with upper rolling eyeballs and posturing. And he used to regain his consciousness within 2 minutes. These symptoms are there since 1 month of duration. His cardiovascular examination is normal. And he was initially evaluated at pediatric neurology department and EEG was found to be abnormal, and provisional diagnosis of cryptogenic generalized epilepsy was made. And his baseline ECG, it was normal sinus arrhythmia with APCs and with no significant abnormalities, and his echo showed structurally normal heart. And then he was started on anti-epileptics. On anti-epileptics, the child presented palpitations after 10 days, and he presented to our emergency department. In emergency department, his ECG was suggestive of regular narrow complex tachycardia, which was probably long RP tachycardia. And then we did 3 days Holter, which showed similar episodes of atrial tachycardia, and there was episodes sometimes terminating with pauses. And then we did a treadmill on him with modified Bruce protocol, and then it was baseline ECG, and then stage 1 it showed sinus tachycardia. Then in stage 2 he started developing ventricular bigeminy, and as exercise progressed he developed bidirectional VPCs, and then it was gradually progressed to multiple ventricular trigeminies and non-sustained ventricular tachycardia. And then it was the recovery, which did not show any QT prolongation, which reverted back to the baseline ECG. And then based on history and ECG and exercise response, the diagnosis of CPVT was made, and he was initially started on beta blocker, propranolol 40 mg twice daily, and he was sent for genetic analysis. Then after 5 days, we have done a repeat TMT, which showed again similar bidirectional VPCs and occasional ventricular trigeminy. And on this, we started on him on flecainide 50 mg twice daily, and in addition to beta blockers. And then we have sent for genetic analysis, which by the time report came, it was showing positive for ryanodine receptor 2 mutation. And ryanodine receptor, this is a sarcoplasmic reticulum calcium release complex in cardiac myocyte. The ryanodine receptor is a large conductance of calcium. It is a junctional protein in sarcoplasmic reticulum. This protein is probability of open of this channel is influenced by many proteins like cardamydoline kinase 2 and phosphokinase A and intra-sarcoplasmic reticular calcium. The cellular pathogenesis of catecholaminergic polymorphic VT, when we start exercising, there is stimulation of beta adrenergic receptor, which causes increase in phosphokinase A, and which also stimulates calcium channels, which increases the intracellular calcium, and it was and also there is increased activity of SERCA. This causes loading of sarcoplasmic reticulum with calcium, whereas in normal myocytes there won't be any calcium leak during diastole because it was not reaching the threshold. But whereas when the receptor mutation is there in ryanodine, it is sensitive to calcium, intrasarcoplasmic reticular calcium, and there is spontaneous calcium release events. When these events happens, and there is activation of sodium channel exchange, and this sodium channel exchange and causes export of calcium out of the cell and import of sodium into the cell, which causes delayed after depolarization. When this reaches the threshold, then it causes action potential. The current hypothesis of CPVT, there are 3 proposed mechanisms. Actually, for stabilization of ryanodine receptor, then there is an intracellular protein FKB which stabilizes and prevents the calcium leak during diastole. And the second is there is increased sensitivity of ryanodine receptor to intrasarcoplasmic calcium. When there is increased sensitivity, there is store overload intracalcium release events happening. And one more hypothesis is unzipping and zipping. The N-terminal domain, there is interaction with the central domain of ryanodine receptor. When this interaction usually happens, this interaction usually happens in closed. Interaction will be opened in systole only. But when the unzipping happens in diastole, there is calcium release events. And management is avoidance of competitive sports, strenuous exercise, and stressful environment, and maximum tolerated beta blocker dose. And most effective beta blocker dose is notalol. And second line like agents like flecainide, which acts on ryanodine receptor and sodium blockade. And later is left cardiac sympathetic denervation and an ICD. In our case, patient had arrhythmic syncope and polymorphic. He doesn't have any polymorphic VT documented, and we initially advised him to avoid strenuous exercise and started him on beta blockers. And further, he had exercise-induced PVC, so we started him on flecainide, and we are awaiting for follow-up. Thank you.
Yeah, very good case. We don't have nadolol available, so we are giving propranolol, right? Yeah.
I said nadolol, we don't have.
The thing is that first time TMT is okay. The second time when we do TMT, we need to be really careful because now we have the diagnosis. Once I had seen one patient who during TMT, once this PVC started coming, then it was continuous beating. This is not easy to cardiovert because until that adrenergic drive goes off, the VT will perpetuate. So will be very difficult to cardiovert again. So the second in TMT, we need to be very cautious.
Thanks.
What is
Thank
the sensitivity of unmask of TMT in terms of reaching the diagnosis or eliciting the PVC or the CPVT as such? Yield of TMT in such a case, the patient, because very often these kids come with syncope and we treat them for seizures.
you.
Did you do
TMT is a useful.
on fluokinate? Did you do TMT?
No, sir, we didn't do TMT after fluokinate.
Generally, CPVT it comes out. We have 11 patients on follow-up. Actually, we had done as a part of the channelopathy protocol. We do TMT of all the first degree related. 50% of them had, in fact, polymorphic complexes on TMT. One of the mother had collapsed on table, who was totally asymptomatic. The child had CPVT.
That TMD has to be monitored always.
We repeated an EEG. We repeated EEG in our hospital. Actually, EEG was done outside hospital, seen by our neurology department, and they started him on anti-epileptics. But we repeated EEG, but the EEG was normal. Okay. No, we stopped.
So the association of sodium channel blockers with the sodium CN5A mutation is well known. In that case, sodium valproate, phenytoin, oxcarbamazepine, lamotrigine, all of them can precipitate. But this association is not known because they are different pathophysiology.
What made you think in terms of CPVT? What was the particular ECG findings? What made you think in terms of
It's a
CPVT?
bidirectional VT
In the initial?
initial.
Yeah, thank you. We'll move to the next talk. Dr. Tina Meriwagis will be presenting polymorphic VT storm in a post-CABG patient. Dr. Tina, please.
Good afternoon, respected chairpersons, teachers, and my dear friends. I am Dr. Tina, DRNB cardiology resident from KHRS Health, Trivandrum, presenting a case of a polymorphic VT, a VT storm in a post-CABG patient. So our patient was a 44-year-old diabetic and hypertensive male who was admitted at another center with infraposterior ST elevation MI. He was thrombolized there, and post-thrombolysis angiogram done showed triple vessel disease. He was advised CABG and he was discharged on medical management. However, he got readmitted there with recurrent episodes of syncope at home. After admission there, he had recurrent VT, for which he was cardioverted and treated with amiodarone and magnesium, and then he came to our hospital for further management. So this was his ECG at admission. In ECG, we can see recurrent episodes of non-sustained ventricular tachycardia, polymorphic occurring. In addition to the recurrent episodes of polymorphic VT, we can also see ventricular ectopics, which had RBBB morphology and with a superior axis, which would locate it to the posterior wall of the LV. Then echo done showed an akinetic inferoseptal inferior and infralateral segments with severe LV dysfunction. His EF was around 30%. He was seen by our cardiac surgeons and he underwent CABG with grafts Lima to LAD and venous grafts to the ramus, RPDA and RPLB. However, in the post-op period, he continued to develop recurrent episodes of polymorphic VT with hemodynamic compromise. He was cardioverted multiple times and he was continued on amiodarone and xylocard infusions. He couldn't be weaned off from ventilator due to recurrent arrhythmias, sometimes agitations and sometimes even stupor, which was attributed to the xylocard infusion also. He then underwent tracheostomy due to prolonged ventilation, but he couldn't be weaned off from the ventilator. So around the 6th post-op day, in view of the continuing recurrent episodes of polymorphic VT, he was taken up for an EP study. So our patient was a young male post-CABG who had recurrent episodes of polymorphic VT by VF storm with significant hemodynamic instability. Unlike the regular monomorphic VT that we see in a post-MI patient, this was polymorphic VT or even VF sometimes with significant hemodynamic compromise. So this was a dilemma in this young patient. This was another ECG of his which showed the recurrent episodes of non-sustained ventricular tachycardia. And mostly we could see that most of the ectopics, there were ectopics which further degenerated into the ventricular tachycardia. This is one of the recordings from his monitor which showed recurrent episodes of VPCs which would then further degenerate into ventricular tachycardia. This was another recording from his monitor which showed a ventricular premature contraction which then further degenerates into ventricular tachycardia with hemodynamic instability and compromise. So our ablation strategy for this patient being an unstable patient, it should be a QCAS strategy, and the target was to eliminate the trigger VPCs that gave rise to the polymorphic VT. He was stabilized with inotropic support and then taken to the EP lab. Our strategy was to do a controlled titration of the Xylocard infusion to precipitate the VPCs to allow for mapping, while at the same time avoiding a ventricular tachycardia. So this was a 3D mapping which was done, and the VPCs, the ablation catheter located in the posterolateral wall, posterior wall of the LV. The VPCs could be seen, and then the ablation catheter picked up a sharp diastolic potential. These were the early areas of from where VPCs were originating. The pointer shows the earliest point of VPC origin which had to be ablated. On pace mapping, VT was VPCs. The VT which was stimulated was similar. It was of similar morphology to the clinical VPCs. And there were continuous, during a VT which was recorded in the lab, there were sharp diastolic potentials that were observed in the ablation catheter. And further scar modification was done targeting the diastolic potential. And then this was 3D mapping showing the points of ablation that was done in the mid posterior wall of the LV where the ablation was delivered, and also the posterior wall of the LV which was scarred and for which substrate modification was done. So finally, the programmed extra stimulation, after ablation, we stopped Xylocard infusion for around half an hour. Routinely, this patient, if we had weaned him off Xylocard infusion or if we had stopped Xylocard infusion for some time, he would continue to get VPCs, which would then go on to become ventricular tachycardia. But then after the ablation, we stopped the Xylocard infusion for half an hour. We observed that there was no more VPCs occurring, and programmed extra stimulation was given, after which we could see no more further VT was induced. So after the procedure, he had no further recurrence of VT. He could be successfully extubated, and he was discharged on oral amiodarone and beta blockers. He comes for follow-up. His EF is around 35% now. He has been advised an ICD implantation, which has not been done yet. Thank you.
I think the potentials that you kept on referring to as diastolic potential, I think those are more of pre-systolic potentials, I would say, as opposed to a diastolic. One thing, these are triggered Purkinje firings, and wherein what is more relevant is that pre-systolic, it is a question of semantics also. And I think you also mentioned about the mid-diastolic potential. That was in sinus, or it was during?
During the VT, sir.
VT.
During.
So we don't think this is a re-entrant tachycardia, isn't it? This is more of a PVC triggering a polymorphic VT.
Yes.
So it is more likely to be a triggered Purkinje.
Yes, sir.
But I think you guys have gone ahead and done some substrate modification also, which might be useful in the long term, I guess.
Yes, sir.
Was the
Did you confirm that? It's a polymorphic VT. So.
Yes, madam. The VPCs which were there clinically, it were matching to the VT that was occurring in the lab on pacing.
Okay, you're telling that the VPC which stimulated
of
the
similar
VT,
morphology.
So
Yes,
taken
ma'am.
that particular VPC and tried to match.
Yes, ma'am.
The VT is anyway polymorphic.
Yeah, yes, madam. It was polymorphic.
the first beat which is precipitating the V.
The VT.
No, it need not be. The VPCs can act as a triggering focus itself in a polymorphic VT, which also was targeted, as well as a scar. I think you cannot not ablate the scar when you go for a ablation.
QT was normal?
QT was normal, sir. Initially, it was around 512. Then it was normal. Yes, CABG was done. So he was post CABG. Yes, so he was on amiodarone and Xylocard infusions. We had even started him on mexilatin. But then he's discharged on amiodarone and beta blocker, sir, metallar. Magnesium, we had given initially, sir, but when his magnesium levels were normal, we had not continued on magnesium. Thank you, sir.
Thank you, Tina. Next, we have Dr. Ainish with this case of isolated LV arrhythmogenic cardiomyopathy.
Good afternoon, everyone. My case is it's a case report on isolated arrhythmogenic left ventricular cardiomyopathy. So our patient is a 59-year-old female who's a known case of hypothyroidism and dyslipidemia, was referred to us in 2015 initially, with history of fatigue, as grade 1 fatigue, and some occasional VPCs on ECG. There was no significant family history, and physical examination was also unremarkable at that time. This was the initial ECG, which showed occasional VPCs. Then we had performed a TMT, which was also initially negative. Echo was also done, which showed mitral valve prolapse with trivial MR. Otherwise, good LV-RV function was there. And we kept the patient on conservative management. In 2000, the patient was kept on follow-up. In 2019, she reported worsening of her fatigue and also started to develop symptoms of dyspnea on exertion. At that time, repeat TMT was done, and it came positive at 9 mets after achieving 85% of the target heart rate. But ECG still showed occasional VPCs. Echo also didn't show any significant abnormality at that time. We advised CAG at that time, but it was deferred to a later date. And then in 2023, after 4 more years, the patient started having persistent recurrent palpitations on exertion as well as at rest, and she also felt her feeling of fatigue had worsened over the time. ECG showed frequent VPCs at this time with an intermittent bigeminy pattern, and echo at that time still showed good LV function. With the mitral valve prolapse, but as you can see, LV-RV function was still normal, and there was trivial MR. And we underwent and did a CAG, and we ruled out coronary artery disease as well, as all the coronaries were normal. And we went ahead and did a 72-hour Holter monitor in view of the VPCs and persistent palpitations. This showed a first-degree heart block with a high ectopic burden of 73,000 beats, around 22.6% over 72 hours in singles, couplets, bigeminy, trigeminy, and quadrigeminy forms. The patient also had 15 runs of NSVT, longest run being of 18 beats, and also multiple supraventricular ectopic beats as well. So we went ahead and did a cardiac MRI, and in the cardiac MRI, the LV and RV systolic functions were normal. There was good LV-RV systolic function with normal morphology. And in the LGE, we found a LGE pattern of enhancement in the basal segments as well as the mid segments, basal anterior, anteroseptal, inferior, and infraseptal segments, as well as the mid anterior, anteroseptal, and inferior infraseptal segments. And this is defined as a ring-like enhancement on LGE because more than 3 contiguous segments in one short axis slice was enhanced. So this ring-like pattern was found to be highly specific for arrhythmogenic left ventricular cardiomyopathy. So we went ahead and did a whole exome gene sequencing as well for this patient, and we isolated a variant in the LDB3 gene, which is known to be likely associated with ARVC. So 26 genes have been isolated to cause ARVC. And out of the 26 genes, these 6 genes, which are part of the desmosomal gene mutations, are known to be associated, have strong evidence and are a definitive cause of ARVC. And our gene we isolated was LDB3, which was classified as a likely pathogenic for ARVC. So according to the latest European task force criteria for diagnosing arrhythmogenic cardiomyopathy, they have divided the diagnosis into an RV phenotype criteria as well as the LV phenotype criteria. So in our patient, in LV phenotype criteria, 2 major criteria were defined. One is the presence of a ring-like enhancement, and one was the presence of low QRS voltages on limb leads, indicating diffuse fibrosis of the LV. So in our patient satisfied this ring-like enhancement pattern, the one major criteria, and we also had 2 minor criteria which were fulfilled, with the presence of a likely pathogenic ACM gene as well as a frequent VPCs of more than 500 per 24 hours. So our patient fit the criteria, and as we've had 1 major and 2 minor criteria, it also came with a definite diagnosis of ALVC. So then we went ahead and we started the patient on beta blocker bisoprolol 5 mg daily, and we also decided to implant an AICD for the patient to prevent sudden cardiac death as a form of primary prophylaxis. And this was defined as a class 2A indication in patient with no evidence of VT or VF, but has a higher arrhythmogenic burden. After 2-month follow-up, the patient had reported her symptoms of palpitations as well as dyspnea have significantly improved, but her ECG still showed occasional VPCs, and the IECD was integrated after 2 months, but there was no evidence of NSVT, VT, or VF. Now we're planning to continue long-term follow-up and integrate the IECD. So it's important to realize This arrhythmogenic cardiomyopathy is a rare cardiomyopathy. Initially, it was defined to involve only the right ventricle, but with the use of cardiac MRIs as well as genetic sequencing, it was soon found that it involves the left ventricle as well. And now we should not miss isolated left ventricular cardiogenic myopathy. So this ring-like enhancement pattern is one pattern which should not be missed on cardiac MRI in patients with a normal LV systolic function as well as normal RV systolic function. And this indicates a need of high index of suspicion in these cases. The pattern can be used to diagnose ALVC and guide genetic testing for mutations in desmosomal proteins, which lead to the detachment of the cardiomyocytes and known to be associated with arrhythmogenic cardiomyopathy. So it's vital to make a timely diagnosis and initiate life-saving measures in the form of ICD implantation for primary prophylaxis, as well as to start on beta blockers. Further investigation is still needed to evaluate the role of ring-like LGE on decision-making and patient management in cases of arrhythmogenic cardiomyopathy. Thank you.
Good case. You are not considering sarcoidosis and or DCM because of the particular pattern.
Yes, sir. That's the main differentiating thing is this pattern, because in a DCM or in sarcoidosis, we'll get a patchy involvement of the LG, but we won't get 3 contiguous segments, which is very specific only for arrhythmogenic cardiomyopathy.
Okay, but my argument was sarcoidosis is much more common and this is rare, but you have genetic analysis to support your claim. Okay.
Yes.
In later phase of sarcoid, any pattern can happen.
Yes.
Once the disease become in the later phase, LG may not distinguish all these named patterns.
Yes.
Yeah. Thank you. Good case.
Thanks.
Is there any other family member effect?
See, I think it's a little too far-fetched to diagnose isolated LV arrhythmogenic cardiomyopathy. For one, there's no evidence of cardiomyopathy. The LV function was normal. And you can get this mid-myocardial enhancement, which is fairly common in DCM, but then still it doesn't show any LV dysfunction. So, even if you get an LV arrhythmogenic cardiomyopathy, RV is invariably involved. It's extremely rare. You could take it as a very rare variant, I suppose.
Actually, ARVC, you have a fibrofatty changes in the RV. But here you have not demonstrated anything. I'm just curious. I don't know anything about this much. Yeah, it could develop in future. But normally when we diagnose ARVC, we normally have the MRI, the histopathological appearance.
Family member affected?
So actually, this patient does not have any children. Her parents actually live in the US, so we were not able to screen them. We're trying to get them to get screened.
What was the morphology of the ectopic? I think I missed it. You showed it in the beginning.
Yes, ma'am. So the ectopic was actually inferior axis LBB morphology. It was not an RBB morphology ectopic. Wait. Yes. And sir, as answering your question, actually in isolated arrhythmogenic left ventricular cardiomyopathy, in this particular variant, it is actually does not involve the RV at all. That's how we differentiate it from arrhythmogenic ARVC, which we commonly diagnose. There's another condition where biventricular involvement is also there, but very rare cases have only isolated left ventricular involvement, where LV function actually gets involved very late in the stage of the disease. Initially, only this ring-like enhancement will become.
In fact, this ALVC concept, American Heart Association continues to go down. European Society writes it as arrhythmogenic cardiomyopathy. In this, previously when ARVC was there, non-desmosomal protein, the Naxos disease and all were associated with the ALVC. Then this subepicardial enhancement is considered to be specific for laminin and desminin and a couple of others. Here the problem, we have this variant of unknown significance and the subepicardial involvement, it could be, but this variant of unknown significance should be established by some co-segregation, that family member having the same phenotype or functional studies or a population model or a computational model as per this American College of Medical Genetics criteria, ACMG criteria.
Yeah,
yes, sir.
See, this is not a subepicardial ring enhancement. So this typically can happen in DCM, but then it does not show any ventricular dysfunction.
Yes.
So I don't think you can basically label it off as this, but on follow-up you should watch out. Yeah. Genetic study is not specific for this.
Thank you, and thank you, Dr. Anish.
Thank you, sir.
We'll go to the next talk, The Pandora's Box by Dr. Nijit.
Good afternoon, all. I'm Dr. Nijin from DM resident from cardiology, Calicut Medical College. I'll be presenting the case of a 31-year-old female patient who presented to us with recurrent episodes of palpitation for the past 6 years and was diagnosed of supraventricular tachycardia and was started on verapamil from outside the hospital. She was having recurrences on verapamil. We don't have tachycardia ECG, but it was documented from outside hospitals that it was a supraventricular tachycardia which was reverting with adenosine. Baseline ECG was normal and her echo was normal. We proceeded with EP study, which was showing 1:1 AV conduction with the AH interval of 61 and HV interval of 38. We started with the retrograde protocols, pacing from the RV apex. It was showing an eccentric conduction with the earliest A in CS 7-8. And as we came down on the cycle length, you can still see that the conduction is non-decremental. We suggesting that there could be a septal accessory pathway. At 260 milliseconds, the pathway reached its effective refractory period, and the ventriculo-atrial dissociation was reached at 220 milliseconds. We paced from HRA as part of antigrade protocol, and the HRA was very unstable. Hence, we changed to CS 5 and 6. Here you can see that the earliest ventricular signal is coming in, suggesting that the pathway is only conducting retrogradely. Tachycardia was induced by extracellular protocol, and tachycardia cycle length was 240 milliseconds. You can see that the earliest A is coming in CS 7-8. Tachycardia was entrained, and post-pacing showed a VAV response with PPA minus TCL of 320 minus 240, suggestive of an AVRT. And since it was a septal pathway, we took CS angio, to rule out coronary sinus fistula. And we proceeded with the mapping of the tricuspid annulus, and the pathway is localized to 4 o'clock position of the tricuspid annulus, and it was ablated. As we were moving our leads, patient developed another tachycardia of cycle length 350 milliseconds. Here the V and A EGMs are almost together. The tachycardia was entrained, and the post-pacing showed a VAV response with the PPA minus TCL suggestive of an AVNRT. The slow pathway modulation was done, and while checking for successful termination of AVNRT, the pacing from atrium showed another tachycardia of almost similar cycle length of 350, but here the A and the V EGMs were separated. You can again see that the earliest A signal was coming in CS 9 and 10. The tachycardia was entrained, and the post-pacing response was VAV response, and the PPA minus TCL was 80, suggestive of another accessory pathway. And since it was closer, the earliest A signal was in CS 910, we thought of another septal pathway. The tricuspid annulus was mapped again, and the accessory pathway was localized to the 6 o'clock position of the tricuspid annulus, and it was ablated. After successful ablation of the accessory pathway, the patient continued to have episodes of tachycardia, but it was very ill-sustained, and it was slower than the previous tachycardia. The cycle length was 420 milliseconds, and the patient was asymptomatic during this period. We were unable to entrain the tachycardia as the tachycardia was very intermittent. Since patient was asymptomatic, we thought we will give a trial of beta blockers and take her for an EP study if the tachycardia becomes symptomatic. Unfortunately, after 2 months of ablation, patient presented again with palpitations. This time we were fortunate enough to get an ECG. Sorry for the poor quality of the ECG. It showed a narrow complex tachycardia, intermittently having sinus beats, and also you can see in the lead 3 inverted P way. The P being inverted, suggestive of a lower right atrial origin of the tachycardia. We took the patient for EP analysis, 3D mapping. and the RA was mapped, and the ectopic foci was localized to the 6 o'clock position of the tricuspid annulus, and it was successfully ablated. And the final diagnosis being multiple supraventricular tachycardia, AVRT, 2 septal pathways which were concealed, and an AVNRT, atrial tachycardia from right atrial lower part, good LV function, and obesity.
The initial EGMs you were saying the earliest was 7-8, isn't it?
Yes.
Do you have a CS? If it is 7-8, it should probably be a little bit on the left side, isn't it? How did you end up
Is
mapping
the
that
catheter
in the
was deep in
tricuspid?
or catheter position was variable, CS catheter?
Initially, the catheter was little out, and maybe it was towards that 9-10 position.
Yeah, I think that is a possibility. The catheter may have been more medial, and then it is also possible that it could have been a wider accessory pathway, which you might have partially got the first time, and then you had gone back and finished it. So it may not be 2 because the location is kind of adjacent or in the similar location. It might have been the same broad pathway which you have gone back and addressed. And it's kind of strange that your AT is also kind of from the same territory that you have. So kind of a strange case.
Any comments, sir, from the audience?
Usually, we routinely start with the retrograde protocol. That's why. We started with then we did the antegrade protocol. The HRA was very unstable, sir. That's why we had to move to CS56.
You didn't have a documented tachycardia prior to the first?
No, sir. All the episodes happened in other hospitals, and the patient had multiple casualty references telling that it was supraventricular tachycardia which was reverting with adenosine.
Maybe it is very useful to study that ECG tolerate. Yeah, prior to. Yeah, RA appendage may give a better stable position. Thank you. We'll move to the next. I think that's the end of the session. Thank you. Thanks for the opportunity. We'll move to the next session. Thanks, Doc.
Moving forward to the second session, learn from the tracings. We welcome the chairpersons onto the stage, Dr. Anis Tajuddin, Dr. Sibu Matthew, and Dr. Sunita Vishwanathan.
Hello. Yeah, we are going to a very basic session because we have a lot of postdoctorals here, and as well as young cardiologists who are interested in EP. The late Dr. Thomas Peter used to say when he came and taught us that if I'm able to ignite a fire in the belly of at least 2 people, then my job is done. So just remember him. He's no more. And Meera is here to talk on how to do a basic EP study, because we saw so many tracings, but I would request that you use a pointer and show what is the crunch and what is being showed by the presenters, subsequent presenters. Meera, I hope you have a pointer.
I think so,
okay. I'll invite Dr. Meera. You all know that she is an electrophysiologist and working at KIMS Health, TRIVANDRUM. Meera, please.
Thank you. Slides.
Presenting from there?
Yeah.
Okay.
So this, as ma'am has said, it's really basics of how to do an EP study. Next slide. So my talk will include about a short discussion about the indications and contraindications, equipment for EP, preparation for EP study, catheters, pacing protocols we'll be discussing a bit in detail, a few examples and summary. Next. The indications, as we know, the most important indication will be arrhythmias. Even though I mentioned sinus node dysfunction as the first indication, we rarely do EP study for sinus node dysfunction these days, because we have other modalities like prolonged Holter, etc., to see whether it's an AV, it's a sinus dysfunction or an AV nodal problem. As far as arrhythmias are concerned, we would like to see the AV nodal abnormality, whether it's a suprahesian conduction block or an infrahesian conduction block. The most important thing is in arrhythmias, we were to determine the mechanism of arrhythmia, location of the circuit, and points which help in ablation of the tachycardia. That is in SVTs. Ventricular tachycardia also the same thing, the location as well as the mechanism of arrhythmias. Evaluation of syncope, again, it is less used frequently these days, except in syncope of undetermined origin, whether we have to see it is VT that is causing the syncope. An indication in certain other conditions where, especially in primary prophylaxis after MI, we can do a VT induction protocols to see whether ICD is indicated, because not all patients can afford an ICD and it is not really indicated. So we can do a VT induction protocols for whether ICD is indicated or not. Another important area is asymptomatic WPW syndromes, which are detected incidentally. We can always do an EP study to look for the refractive period of the accessory pathway to decide on whether ablation is required or not. And last but not the least is for ablation of arrhythmias and to assess the relation, the result of an ablation, whether we have successfully ablated, what are the chances of recurrence. The absolute contraindications are patients with acute coronary syndrome, heart failure, any bleeding diathesis, any arrhythmogenic conditions which are correctable, like electrolyte abnormalities and record toxicity, etc., which needs to be corrected before we do an EP study, and of course, pregnancy. Next. So the basic structure, the basic circuit involves pointer. You have the CM. Okay. The circuit basically consists of the multiple catheters which are connected to a junction box. From the junction box, it is connected to the stimulator, and another from the stimulator it goes to the amplifiers, and from the amplifier it is connected to the EP recording system as well as a printer. So in this particular cartoon, I have not included RF energy because this is for EP study. Next slide. Yeah, in this one, actually, I have incorporated the 3D mapping system along with the conventional mapping system. On the left-hand side, we can see the conventional mapping system, and on the right-hand side, I've tried to incorporate the 3D mapping system. It has got an additional workstation, and the number of junction box, number of catheters and junction box, is more in 3D system compared to the conventional system. And when you have an RF generator in the circuit, you have a different, you have an indifferent electrode as well as a major RF patch which is attached to the patient. That is in addition to the conventional EP study system. So this is the 3D mapping system. And in addition to that, the patient should have an external defibrillator as well as a temporary pacing system. And a fully equipped resuscitation cart is a must. Intravenous infusion systems with necessary drugs and solutions, and a standby equipment if available with qualified personnel, maybe an echocardiographer or somebody to help you with a pericardial aspiration, etc., and a ventilator, of course. Next. The preparation, preferably fasting should be done for at least 6 hours. Antiarrhythmic therapy should be withheld for at least 4 half-lives. That is very important because if we do not withhold the antiarrhythmic therapy, finally we'll end up having an EP study without any use. That is, we may not be able to induce a tachycardia at all. So at least for a period of 4 half-lives, the antiarrhythmic therapy should be withheld. OHA dose should be appropriately readjusted so that the patient doesn't go into hypoglycemia. We need not withhold the anticoagulant therapy if it is a NOAC. But if it is warfarin, it is preferable to withhold the warfarin for 3 to 4 days. Bridging therapy is generally not indicated. Adequate IV fluids and other accessory things like pulse oximeters, NIBP, etc. needs to be used. Yeah, this is the most important. What is the difference between a surface ECG and an EP study? We need to look at the His bundle electrogram. So how do you look for, how do you identify a proper His bundle electrogram? It is either a biphasic or triphasic sharp potential between the atrial and ventricular signals with a isoelectric line separating the His bundle electrogram from the atrial and ventricular electrograms. And fluoroscopically, we use 3 views, AP view, RAO and LAO views. RAO both 20 to 30 LAO and 30 RAO, 30 degrees RAO. The His bundle catheter will be located in the middle, pointing towards the septum. And then you have the RV apex catheter at the RV apex and a coronary sinus catheter which can be inserted from above or below. It is a decapolar catheter, and all the other catheters are usually quadrupolar catheters. The electrograms in the coronary sinus catheter, it has got A and B. It has got simultaneous A and B. That is, after inserting the coronary sinus catheter and connecting it to the junction box, we will be able to identify A and B signals in the coronary sinus. A word about signals, unipolar versus bipolar. All the catheters we can record both unipolar as well as bipolar. So what is the advantage of unipolar over bipolar? In unipolar, the catheter tip acts as the cathode and IVC acts as the anode. So if a circuit is, if a tachycardia or if there is a pathway in one particular area of the heart, and if you use a unipolar electrogram, you will get a sharp negative deflection in that unipolar electrogram. It is a very helpful adjunct in ablation of pathways as well as focal tachycardias. So there is no summation of electrograms in a unipolar electrogram. Whereas in a bipolar electrogram, the catheter tip has got two electrodes, and so the current goes from the catheter tip from the positive to negative. So we have a summation electrogram with a biphasic bipolar summation we can get. So unipolar has got certain advantage, but the disadvantage is that it is susceptible to noise. So most of the times we use a bipolar, except when you have a pathway or when you have a focal tachycardia, we use a unipolar electrogram. Now the measurements, these are the four basic measurements: PA interval, AH interval, H interval and HV interval. PA is actually measured from the onset of P wave to the onset of A in the His bundle electrogram. And this is basically represents the intra-atrial conduction time. The normal value is about 25 to 55 milliseconds. AH interval is measured from the onset of atrial signal to the His bundle signal in the His bundle electrogram, and it represents the conduction time through the AV node, and values about 55 to 125 milliseconds. H interval is again the duration of conduction across the His, and it's less than 30 milliseconds. And the most important, HV interval. Next. Now the protocols, we know cycle length and program stimulation, and the most important is program stimulation. We'll go to that. Next. Yeah. First, extra stimulus spacing. So after we give a basic impulse, that is a train of stimulus for about 8 to 12 beats, we induce premature impulses at specific coupling intervals. These are called as extra stimuli, and these extra stimuli are given at decremental values. That is, we start with a particular value and we go down and see whether it is capturing and whether it is causing any tachycardia. So we'll go into that little data. What is the definition of a coupling interval? Coupling interval is a time measured in milliseconds between a normal impulse and a premature impulse. It is induced through program stimulation. And next is the effective refractory period. What is the effective refractory period? It's the longest coupling interval at which a premature impulse fails to propagate through the tissue or the structure. Next. Yeah. So if this is an intracardiac electrogram, if you look at the second part, that is a repolarization part. After the depolarization, we have the repolarization. The first part is the absolute refractory period, and the second part is the relative refractory period. In the absolute refractory period, even if you try to stimulate the myocardium, it will not capture. Whereas in the relative refractory period, there are various zones. So in the next cartoon, we can see that first S1 is captured, and when we keep on reducing the that is coupling interval, at one particular point, it will produce a stimulation artifact, but it will not capture. That is the definition of effective refractory period. The coupling interval in which it stimulates, it captures a ventricle, it causes an artifact, but it does not capture the myocardium. That is the effective refractory period. So atrial pacing protocols. First we do a ventricular pacing protocol, then we go for the atrial pacing protocol. First we have a burst pacing, then refractory pacing, and measurement of Engelbach cycle length and atrial effective period. Next. A word about decremental and non-decremental conduction. What is meant by decremental conduction? By definition, AV node has got a decremental property, and pathways have got non-decremental properties. There are exceptions. There are pathways which have decremental properties, but for practical purpose, AV node has got AV node is a tissue which has got decremental property. So when you give stimulus with increasing prematurity, the impulse gets slow, the conduction gets slower and slower. That is decremental conduction. Whereas non-decremental means all or none phenomenon. But when you keep on reducing the refractory period, they does not prolong further. The conduction does not prolong further. At the same time, it stops conducting. That is all or non-conduction. This is non-decremental conduction. So this is what I mentioned. First we give one stimulus, and S2 we are giving. You measure the AH interval in the first tracing. In the second tracing, when the coupling interval is reduced, the AH interval prolongs. So this is a decremental conduction. Next. Now, how do you measure the Venki backing? See, first you give a stimulus. If you look at the atrial channel, you can see that we are pacing the atrium. First you see AHV in the first pacing beat. Second, the AH prolongs, second pacing beat. Third, again the AH prolongs. And if you look at the last beat, there is no AH is absent. So that is a drop beat. That is a Venki back cycle length. So if you look down, the Venki back cycle length of this particular patient is 390 milliseconds. Next. Then what is this atrial refractory period and AV node refractory period? So again, based on the refractory pacing, first is 500 milliseconds. First we give an extra stimulus at 250 milliseconds. You can see that there is an A and H, A and A2 and H2. There is an atrial stimulus and atrial electrogram, and H is delayed, and there is a ventricular electrogram. That's a normal pacing with the delayed AH. When you go to the second tracing, we have a stimulus, we have an atrial electrogram, but there is no H and V. So that is a AV nodal effective refractory period. When you go to the third tracing, you have a stimulus, but you don't have an atrial electrogram or any further conduction. So that is the atrial effective refractory period. The stimulus doesn't even capture the atrium. So these are the parameters which we determined by atrial pacing. Next. In the retrograde pacing, actually retrograde pacing is done earlier than atrial pacing, as you all know. It's the same thing we do here. We do an incremental pacing, extra stimulus pacing, and we measure the ventricular effective refractory period and when VA node effective, VA refractory, that is retrograde effective refractory period and ventricular effective refractory period.
Excuse me, Meera, can you, because of time, we can,
Move forward. So we have the retrograde pacing protocol. And VA block, we can see, this is the 390, that is burst pacing, we can see the VA block. Next. This is a decremental pacing, VHA. Central conduction with the earliest in his and followed by CS. Eccentric activation. This is not a pacing, but this is a tachycardia. You can see that the earliest A is in the CS12, that is a distal, and it is going towards the.
I'm afraid we have to stop, Meera, because it is a wonderful lecture. Because we need at least a couple of questions from the audience. Any doubts? And we are going for, I think Dr. Anand is going to discuss on laboratory on mapping techniques. So, any questions? Can you go to your last slide, please? Because see, I think it's what the point which was raised is very important, because if you are chasing an atrial tachycardia or supraventricular, I think you should do the ventricular protocols first. That's what we used to do. And ventricular, you do the atrial, but do all, finish all, and then go ahead with your diagnostic. And I think Dr. Anand is going to discuss mapping techniques. So I think we'll go for that for want of time. Okay. Yes, Dr. Anand.
Thank you. A very good afternoon, and appreciate the opportunity to present. I'll be talking on, it's a short talk again, only for 10 minutes, on conventional mapping techniques in the EP lab. I'll probably only have time to touch upon a couple of salient points. Wanted to start with the basics, which luckily Dr. Meera had already talked about. Bipolar electrogram signals are the basic variables that we get, that we work with in order to figure out the arrhythmia. Unipolar electrograms are something which are, I think, is probably still very underutilized and is of extremely useful. Dr. Meera told you about how it is configured. It is most useful in focal tachycardia because you will get a QS pattern when the distal map is at the point of origin of the tachycardia. This is mapping a pathway in a WPW. The first slide is not in an ideal position. The second one is in a better position. So this is the ablation unipolar. You see that there is a slight R before the Q starts, as opposed to the second position, where you have a QS pattern and a very steep downslope corresponding to an early signal in the ablation distal. And this could be a good spot as far as figuring out the accessory pathway is concerned. This is mapping a PVC from the RVOT. This is the unipolar signal, and this is the ablation distal and proximal. It is always good to interpret both the bipolar and the unipolar together to get an idea. Focal tachycardia and focal PVCs, you want to, the reference point that you use is the earliest QRS of all the 12 leads that you can obtain. And then the signal should be at least 10 to 40 milliseconds earlier than the earliest QRS. These are a couple of examples where we are comparing both the bipolar and the unipolar. You have an early signal in the bipolar, which is 20 milliseconds early, but you have an R wave in the unipolar, so probably not ideal. Here, the unipolar looks more like a far field. Here, and then here you have a very early signal of almost 70 milliseconds with almost this pre-systolic potential, which we were referring to earlier, and a double negative unipolar indicative of a good spot. It's not only the wavefront, but also a sense of the myocardium that you get with the electrograms, bipolar electrogram. If there is a scar or there are potential slow conduction areas, the electrogram will be fractionated. Mapping can be anatomical, activation, pace mapping, and entrainment mapping. The anatomical approach is probably most useful as far as SVTs are concerned, particularly in AV and RT. You have the reference catheters, which gives us an idea of roughly where the anatomy of the slow pathway is. And you place the ablation catheter there, and then you map for a fractionated low voltage atrial signal, as you see here, which is usually a good site for a slow pathway ablation. There are advanced techniques which can map the slow pathway as a low voltage area and an area of wavefront collision. These are more of academic interest because using a 3D mapping for an AV and RT may not be economically viable. Mapping for an AVRT or a WPW, you want to have a good sense of what is the circuit of the arrhythmia. For WPW, you can map the pathway in sinus rhythm. You put your CS across and you look for the earliest V on the CS catheter. If it is a concealed pathway without any delta, you can map the earliest A while ventricular pacing or during the tachycardia. This is an example of a WPW, and you see that the earliest, there is a delta wave on the surface ECG, and the earliest ventricular potential is on CS distal. Ideally, a CS should be bracketed so that you make sure that you are beyond the pathway and the earliest is somewhere in between. You can also pace from the ventricle and look for the earliest atrial electrogram in the CS, and this is a well bracketed CS as you see, and the earliest A is on the CS2. Again, 3D mapping using HD grid and high definition mapping can be made use of even for pathways, but may not be economically viable. If it is a large atrium and if you're not able to exactly locate it, you can use high definition mapping, and activation mapping can be made use even for locating of a pathway potential. Moving on to activation mapping, you need the tachycardia to be sustained. You need to have a good idea of the tachycardia, whether it's a focal or a macro reentry. You need to have an idea of where the chamber of origin is, particularly in the atria, if it is left or the right. And very important to set your reference point. Understanding of mechanism of arrhythmia is probably the most important as far as mapping is concerned. It can either be reentry like AVNRT, AVRT, flutter and a scar mediated VT, or an automatic or triggered focal arrhythmia as in the case of an atrial tachycardia or an outflow tract ventricular tachycardia. Focal tachycardia, again, setting the reference point is important. If you're looking at an atrial tachycardia, your earliest P wave is going to be a reference point, and then you map for the ablation catheter showing signal at least 10 to 40 milliseconds earlier than the earliest P wave. Here, clubbing that with a unipolar will be useful. Here you see an early signal on the distal ablation corresponding to a
steep QS pattern in the ablation. Similarly, mapping of focal PVCs, clubbed unipolar and bipolar, you see here. The reference point here is going to be the earliest QRS of the 12 leads. And you look for a signal which is at least 10 to 40 milliseconds earlier than the earliest QRS. When it comes to macro reentry, setting the window is important. Here, obviously, a 3D mapping is required. Usually a reference point, which is an internal reference point, such as the CS, is taken because which is more stable and well demarcated as opposed to picking up a P wave. And then you set the window of interest to almost 90% of the cycle length. Here you see that the duodeca catheter captures almost 100% of the tachycardia cycle length, indicating that it is a macro reentrant tachycardia. And you have the early meets late, indicating that the entire tachycardia is within this particular chamber and it is a macro reentry. As far as ventricular tachycardia is concerned, activation mapping can be helpful in terms of figuring out where the isthmus is. And then you do a local mapping to look for mid-diastolic potentials. And then entrainment mapping should ideally be done in order to make sure this is not a bystander pathway and make sure that this is an area of interest. So either you look for a mid-diastolic potential or you look for a continuous electrical activity in the diastolic period, indicative of slow conduction within the scar or isthmus, which might be a high yield spot for ablation. The fourth modality is a pace mapping, particularly in cases of PVCs. If the PVCs are infrequent, you capture your PVC of interest and you pace the area of interest and see how much the paced QRS matches with your original PVC. This obviously ideally is done with 3D mapping because you have to designate the point and go back to the point with the best match and ablate that particular spot. There are automatic algorithms which will give you a score. If there is a 12 out of 12 match, that will be a great area. And you allocate these points. If you don't have a great match, you move around and you pick the one with the most match and go for ablating the same. I think in the interest of time, I will stop this. I've covered some of the conventional mapping techniques. I'll probably just mention the advanced mapping techniques. We talked about local activation map a little bit, important for both focal as well as reentrant tachycardia. Fractionated map and late potential map are relevant for scar-mediated ventricular tachycardia. You do a good voltage map and you tag all the areas of fractionation, which could be potentially part of the circuit. And you can go back to these points and
Dr. Anand,
do
we can,
an entrainment mapping.
We can ask questions
yes.
so that
yes. So I think I'll stop there. Thank you.
Stopped, I mean, on time. Yeah, few minutes for questions because this is basic. I think it is useful if some questions are coming and that will be useful.
Can I ask Dr. Ambudri one question? So what is the use of 3D mapping in WPW syndrome with Epstein's malformation? So do you routinely use? Yes, Anand?
I think sir can respond to that.
Generally, it's not routinely done, but this open window mapping can be done with a 3D as an additional feature. That we don't annotate this ventricular or atrial electrogram, the earliest electrogram irrespective of that. So it will come like a continuous activity because Epstein is an ideal case because you have multiple accessory pathway and the electrograms, sometimes even with manual annotation, you won't be able to differentiate between atrial and ventricular. I think this time IPGA, Dr. Ulyas has published a case report on the same topic, that is on WPW, Epstein, and open window mapping. Shabiri is one of the authors.
I think they say that the average time for routine 2D ablation is around 7 hours for Epstein. I don't know.
No.
If there are multiple pathways. I read one article. So I think probably this will shorten your time.
Not
No,
more than
Anand.
60 to 90.
So Anand, is it important for every case that you use unipolar and bipolar? Because I saw most of your tracings were like
it
that.
helps to always have
Yeah.
one. You never knows when it is going to be helpful actually.
Mhm. Oh, okay. Any more questions? Regarding the RVOT VTs or VPCs, you showed one point of ablation, but sometimes you need multiple areas of ablation. That's what you see most of the
Yes,
times.
ma'am. Probably a
Yeah.
slightly broader region might need to
Yeah.
be modified.
Okay. And how often have you encountered ablations in the PA, like distal RVOT?
Occasionally, yes. So these points of transition is what is usually arrhythmogenic. So there are these muscle cuffs, just like how AF comes from the PV cuff. There are kind of muscle cuffs at the transition of pulmonary artery and the RVOT. So sometimes you can have very high origins of these PVCs as well.
Any questions from the audience?
So this is a very basic question. How do you do unipolar and bipolar together?
No, it is just a question of how you're giving the input to the system, as Dr. Meera was explaining. The cathode is the tip of the mapping catheter, and the second one is usually outside the heart. It can be from the IVC, or it can even be a surface electrogram. I think can be connected as the second pole.
So can you get both the tracings together?
Yes.
It's a wonderful talk, Dr. Anand, and I'm sure it was useful for everybody. So I think we will move on to the next talk now by Dr. Anis Tajuddin. He's going to crack a very difficult topic, that is entrainment from bench to bedside. Okay, Dr. Anis.
Thank you, Jody and organizers, for the invitation. So my talk is on entrainment. I'll just be focusing more on the basic aspects of entrainment and not too much on the advanced aspects which is used in some arrhythmias like VT. So entrainment is a procedure which we do in patients when there is re-entry. And as you know, re-entry is a mechanism of almost or the most common types of arrhythmias which we manage in the EP lab. So in re-entry, there will be an isolated myocardial segment which is maintaining the tachycardia. And along the circuit, there will be an activation or an activation wavefront which is spreading around the circuit. And as told already, when the activation wavefront spreads, there is a time during the after the depolarization, there is something called the absolute refractory period, and then there is relative refractory period. And so at the tail of the activation front, there is an excitable gap. So when the impulse has gone through, when the muscle is again excitable, that is the excitable gap. So if an impulse from outside, like a pacing stimulus from far away from the circuit, can enter the excitable gap in the re-entry and entrain or reset or up the tachycardia, it is called entrainment. So this is a tachycardia and there is an excitable gap. Now, if you pace at the rate of the cycle length of the tachycardia, nothing might happen. You might get a fusion of a complex between the tachycardia beat and the pacing beat. But usually the tachycardia is not entrained. But when you pace slightly faster, this extra stimulus can enter the circuit and reset the tachycardia. Now, entrainment is just continuous resetting of the tachycardia. The QRS at the time when you are pacing at a faster cycle length can be fusion between the morphology produced by the tachycardia and morphology produced by pacing. So for sake of easy understanding, we are talking about possibly entrainment in the ventricular tachycardia. Now, if you pace very fast, for instance, if you, in this case, let's assume that the stimulus is actually given in the circuit. If you pace very fast, it sets up two wavefronts in opposite direction. One is the antidromic direction, which will collide with the oncoming impulse in the circuit and will terminate the it can abolish the further circuit of the further propagation of the impulse, and an orthodromic impulse also, which can encroach onto the refractory period of the tachycardia, and then it can terminate the tachycardia. This is the principle of tachycardia termination using ATP or ventricular overdrive pacing. Now, if it is just lower than the tachycardia cycle length, like say the cycle length initially was 300 milliseconds and you are pacing at 280 milliseconds, the antidromic wavefront will go back, and there is actually interruption of the arrhythmia circuit. But in the orthodromic digression, the new impulse can spread and assume the same tachycardia pathway. So in effect, you are actually driving the tachycardia at a faster rate, and even though you are interrupting the tachycardia with each impulse, the tachycardia is at this point considered to be entrained. So the tachycardia cycle length at this time will be equivalent to the pacing cycle length. So if you are pacing at 280, the cycle length is accelerated to 280, but the QRS morphology of this arrhythmia will be exactly like the tachycardia circuit, because we are pacing from within the circuit and we are not expecting any activation to go outside of the circuit. So this is called entrainment, and in this case it's also called entrainment with concealed fusion. So there is entrained, other word is continuous resetting of the tachycardia. Surface ECG will show the same activation QRS, but with cycle length now the pacing cycle length, that is 280 milliseconds. Now, for the requirement of entrainment, you need a few things. One is the circuit of myocardium with an electrical barrier. If there is no electrical barrier which prevents the spread of activity around the circuit or abolishes the circuit, then there will not be any entrainment. And then a propagating impulse and an excitable gap, as I mentioned. Now, after the last paced beat of the tachycardia, of pacing, the return cycle length is very important, and it's used for various observations. So assume there is an electrode sitting on the tachycardia circuit, and there is an electrode also at the pacing catheter tip. So with the last beat, so the signal spreads like this around the tachycardia cycle length, but after the pacing is stopped, it takes an additional 20 milliseconds for the signal to come back to the same electrode. So the return cycle length is always the tachycardia cycle length. It is not 280 milliseconds, so it will be 300 milliseconds. And the last pace beat will be also same as the QRS morphology during tachycardia. If there was, because this is already a concealed stimulation, the QRS is already like a tachycardia QRS, and the last, after termination of pacing, the return cycle will also show a same QRS like tachycardia, and the return cycle length will be 300 milliseconds because we are pacing from inside the circuit. So 280, and then the return cycle length will be happening at 300 milliseconds. Now, if the same procedure can be done by pacing at a site far away from the circuit. Say we are pacing 30 milliseconds away from the circuit, we are capturing ventricular myocardium, but it takes 30 milliseconds for the signal to reach the circuit. But once it reaches inside the circuit and excites the excitable gap, it behaves like a pacing stimulus inside the circuit. So it will go on like this, and after the last beat of pacing, it will exactly the QRS will exactly match the QRS of the tachycardia. It will not be like a pacing beat. But during the pacing time, because we are pacing outside the circuit, the QRS morphology will be a fusion between the tachycardia QRS and the pacing site QRS. So if you are pacing from the RV apex and there is a ventricular tachycardia going on, the QRS morphology during pacing will be a fusion between the RV apex and the tachycardia, maybe from the left ventricle. But after pacing is stopped, then the return cycle QRS will be like the tachycardia, and the tachycardia will continue. But since the electrode is now located 30 milliseconds away from the tachycardia circuit, the return cycle length to the circuit is 2 times the distance from the circuit to the electrode. So initially it took 30 milliseconds to reach the circuit, and now it will take another 30 milliseconds to come back to the electrode. So the return cycle length will be, instead of 300 milliseconds, it will be 360 milliseconds. So this is the post-pacing interval. That's the measurement from the last stimulus to the return at the return to the electrode where from it is stimulated. So what about the QRS morphology while pacing? As I mentioned, because we are pacing from outside the circuit, it will be a fused QRS complex, and this is called manifest entrainment. Previously, when we were pacing from inside the circuit, it was concealed entrainment with concealed fusion because the QRS was exactly like the tachycardia. So just a few slides on the rules of entrainment. As I mentioned, there is a constant fusion at constant pacing cycle length. So suppose you are pacing at 280, you will get a constant fusion morphology. If you pace faster, you will get a further different QRS morphology, but that will be a same fusion QRS complex for a longer time. And at each stimulus, there is actually interruption of the arrhythmia, but continuation of the conduction along the orthotropic direction. And during in atrial tachycardia, re-entrant atrial tachycardia, where the QRS morphology is not appreciable or the change in P wave morphology is not very appreciable, you have to depend on intracardiac electrograms, and this will also show the same features of concealed fusion or manifest fusion. So this is what is happening here. So in this case, there is a VT going on, and the first patient, we are overdrive pacing from the RV. It is called overdrive pacing. But the QRS morphology is not like RV pacing. It is a fusion between the QRS morphology of VT and plain RV pacing. So this is manifest fusion. If you pace faster, like 390 milliseconds, you will get a different QRS morphology. This is called progressive fusion. That is another morphology of QRS at faster pacing cycle length. And if you pace pure RV pacing, when there is no tachycardia, you are pacing RV, the morphology is different from the fusion complexes. So that is the importance of entrainment, and this has to be demonstrated, that is both manifest fusion and progressive fusion at faster cycle length to show that entrainment has happened. I will just stop with one slide. This is a VT going on, and there is pacing during VT. You can see that during pacing, the VT is accelerated to the pacing rate, and then you have to look at the morphology of the QRS complex, whether it is actually exactly the same as the ongoing VT after stopping. If the morphology is the same as VT, then it is called entrainment with concealed fusion. Then you have to look at the post-pacing interval. When you look at the post-pacing interval, you have to look at the signal which has been actually captured by the pacing stimulus. Here you can see this interval of say 100 milliseconds between the pacing stimulus and the QRS onset is the same as this interval from this small signal here to the QRS onset. So this is the signal which is captured. So measuring the post-pacing interval is from this signal to this small signal here in the ablation catheter from where pacing was done. So that is the post-pacing interval. I don't think we have further time for discussion on atrial arrhythmias like flutter. So I will take questions if there is.
What happens in atrial flutter?
Yeah.
Atrial flutter, just show that. So I think, can you just summarize that the basic essence of re-entry? You said it's a continuous resetting.
Re-entry, entrainment is continuous resetting of the tachycardia. It happens only when there is a re-entrant circuit, a myocardial impulse propagating around a circuit with electrical boundaries which permits the conduction and an excitable gap. So almost all arrhythmias where re-entry is suspected, entrainment can be elicited even in AVRT or AVNRT, and each has to be interpreted differently depending on what we look for is different in each arrhythmia. For example, in flutter, we are looking for concealed entrainment or concealed fusion from the isthmus, and also to rule out, for example, I will just show one signal here. So this is a cavo-tricuspid isthmus flutter, counterclockwise direction. Just by pacing from CS distal, we can exclude that left atrium is part of the circuit, because from CS distal you have entrained the circuit, but the post-pacing interval is very long at the CS distal catheter, which indicates that the left atrium is not part of the circuit. And combined with other activation mapping and everything, we make a diagnosis of RA flutter. So depending on the arrhythmia question, you have to use entrainment to get the maximum value out of it. So I think that will be a different discussion.
Can you differentiate between a spontaneous termination and you
mean pacing termination?
Yeah.
Pacing termination can happen when you try to entrain it, and there is no definite way of absolutely determining whether it terminated spontaneously, or if the QRS has been accelerated, or if any of the circuit has been captured as demonstrated by change in activation pattern in the intracardiac EGMs. For example, there is a halo catheter in the right atrium. So when you are pacing somewhere from the left atrium, there is a sudden change in activation pattern in the right atrial signal with termination of tachycardia. You can assume it is due to overdrive pacing termination.
Any questions?
Yes.
Atrial pacing and entraining of a ventricular tachycardia. I mean,
Yeah.
usually people do that, no?
Yeah, we can do both atrial pacing for VT as well as ventricular pacing for.
Is it
atrial
useful in focal atrial tachycardias? I mean,
So if it's a focal
triggered-
atrial tachycardia and re-entry is not a
not a-
mechanism,
yeah. So then
you
that way you
do
can
a
exclude.
procedure, similar procedure, and
Yeah.
that is called overdrive pacing.
Okay.
It should not be called as entrainment.
Okay.
Because you will either accelerate or terminate you can override, suppress the atrial tachycardia or terminate the atrial tachycardia. In that case, you will not be able to demonstrate constant fusion. So that is why entrainment is not there.
And after stopping the pacing, the tachycardia should continue.
It can continue, but these principles of entrainment cannot be demonstrated, like progressive fusion, and it will not be a constant post-pacing interval, things like that.
Okay, I think he has any more questions or clarifications? We have 16 minutes to go. I think it's really partly demystified as far as I'm concerned. I think we have to go and do our homework. Okay. Good. Thank you, Anis. I think you've done well. Thank you.